Hello and welcome to this brief input on the topic of diagnostic errors. In this talk, I will focus on the aspect of decision making and place it in a clinical context. My name is Sven Staender. I'm a specialist in anesthesiology and intensive care medicine and a member of the Competence Center for Medicine, Ethics and Law at the University of Zurich. So what are we actually talking about? What is it about the subject of diagnosis? Is it really something that needs to be addressed in a patient safety awareness week? In fact, many people are unaware of the extent of the problem of diagnostic errors in medicine. And that is not really surprising because diagnostic errors often go unnoticed. Choosing the wrong side of surgery is clearly noticeable. A diagnostic error is often only recognized when the initiated treatment is unsuccessful or when the symptoms and the course of the disease become so pronounced that the diagnostic error becomes evident. To get a better understanding of what we are talking about, this systematic review by Newman-Toker from December 2022 is helpful. This group has compiled almost 280 publications on diagnostic errors in emergency departments and published them in a highly recommended document. This table shows the top 15 most common conditions that account for 68% of diagnostic errors in the emergency department, where only the first 5 conditions, like stroke, myocardial infarction, aortic aneurysm, spinal cord compression, and venous thromboembolism, already account for around 40% of serious misdiagnosis-related harm. Overall diagnostic accuracy in the emergency department is high, but around 6% of patients receive an incorrect diagnosis. This translates to about 1 in 18 patients in the emergency department receiving an incorrect diagnosis, 1 in 50 suffering an adverse event, and 1 in 350 patients suffering permanent disability or death. Another publication from the same group around Newman-Toker was published just last year. The study attempts to quantify the issue of diagnostic errors and harm caused. This table shows diagnosis from the so-called Big Three, namely vascular disease, infections, and cancer, and the corresponding error rate. The right-handed column shows the corresponding rate of patient harm. Even there is quite a large difference between the rate of errors on this column and the rate of harm on this column. The total number at the national level is worrying. The study is methodologically complex because it combines prevalence data and frequencies from the existing literature on disease-specific diagnostic errors. Nevertheless, this study provides the first national estimate of permanent morbidity and mortality resulting from diagnostic errors across all clinical settings in the US. They estimated the total serious harms in the US to be around nearly 800,000 cases each year. We doctors are often unaware of this high rate of diagnostic errors. This was demonstrated by a somewhat older publication from 2013. In a simulation study, a total of 180 physicians correctly diagnosed 55.3% of easier and 5.8% of more difficult cases. Despite a large difference in diagnostic accuracy between easier and more difficult cases, the difference in confidence with their diagnostic accuracy was relatively small. So diagnostic accuracy was worse for more difficult cases and characterized by overconfidence in accuracy. This study suggests that physicians' level of confidence may be relatively insensitive to both diagnostic accuracy and case difficulty. This mismatch might prevent physicians from re-examining difficult cases where the diagnosis may be incorrect. What is the reason for this? Basically, the origin of almost all of these problems is the bright and dark side of having a brain. Our brain does indeed perform fantastic things, but it is subject to a whole range of influencing factors. When it comes to decision making, for example, we have internal influencing factors such as knowledge, experience, but also physical fitness or fatigue. However, we also have external factors that influence our decision making, such as stress, distraction, or noise. But other factors also affect our ability to make a correct diagnosis. For example, the context in which we work plays a role because it makes a difference whether you are assessing a patient with, for example, a chronic cough in a Swiss university hospital or in a hospital ward in Africa. And yet, in both places, you must consider extrinsic asthma as well as tuberculosis as a differential diagnosis in such a case with chronic cough. Decision-making also depends on personality. For example, our personal willingness to take risks plays a role in our decision-making. So whether you play mini-golf or you go skydiving in your free time has an influence on your decision-making. This study examined how personal willingness to take risks influences whether a patient is admitted to hospital or sent home after an emergency consultation. After adjustment for clinical factors, the physicians who had high risk-taking scores, the so-called risk seekers, admitted only 30% of the patients they evaluated, compared with admission rates of over 50% for physicians who had low risk-taking scores, the risk avoiders. And although there was no evaluation of the appropriateness of these triage decisions, this difference in the handling of adjusted cases was significant. Daniel Kahneman has published this knowledge about our way of deciding in a highly recommended book, Thinking Fast and Slow. The idea behind it is that we basically have two principles of reasoning, non-analytical and analytical thinking. This is also known as the dual process theory. Analytical thinking is considered to be slow, careful, often rule-based, strategic thinking, while non-analytical thinking is characterized by quick, intuitive, and often emotional decision-making. Pattern recognition, framing effects, or heuristics play a role here. In pattern recognition, for example, we recognize patterns and sometimes, like in this cartoon, misinterpret them in context. And in heuristics, our brain takes a mental shortcut, simply to save energy, as in this picture with a shortcut through a roundabout. This is actually quite useful from the aspect of saving energy. However, heuristics can play a trick on us in decision making. This is a partial list of the typical heuristics in the diagnostic process. Anchoring, for example, means that we are influenced by the most recent experience of a similar case. The availability heuristics, on the other hand, limits the differential diagnosis to only the common ones. During the cold season, every cough is considered a cold. Hierarchies may come into play in the heuristic called blind obedience. A very powerful heuristic is confirmation bias. Here, facts are evaluated based on whether or not they confirm our initial idea. The fatal consequence of this heuristic is that facts that do not confirm our hypothesis are ignored or suppressed. Good clinicians know that in the diagnostic process, particular attention must be paid to facts that even do not confirm the hypothesis. On a conceptual level, decisions can be differentiated by their relative degree of uncertainty because some decision situations offer more information about the expected outcome than others. Each decision can be placed on a continuum from no certainty through uncertainty, risk, and finally to certainty, where only a single outcome is known to result. Humans follow the rules of probability. Thus, if outcome probabilities are specified and therefore certainty is high, decisions can be made strategically. In these situations, individuals can generally calculate the risk associated with each choice. If uncertainty, on the other hand, exists to a moderate degree by offering only some indicators of possible outcomes, then both systems of the dual process theory may act in concert. On the other extreme, when the decision is associated with complete uncertainty, then a strategic choice following the rules of probability is not possible. That means when the situation does not offer appropriate cues to make a strategic decision, then the fast, intuitive, experiential system may play a role compared to the situation that allows calculation of probabilities, where the slow, more rational analytical system comes into play. The processes behind these decision patterns are well studied, and stress seems to play a significant role here. So how can we deal with this? One of the possibilities is teamwork, because when we think in teams, we simply come up with many more possibilities. The buzzword here is the concept of shared mental models. So when you hear the word apple, some may think of the fruit, and others may even think of a computer. The crucial point is that we have to talk about it, because you can't see from the outside who has which mental model in mind. There are several tools that enable shared decision-making. Talking to the room, for example, allows the team to keep track of what each person is thinking about and gives team members the opportunity to get involved in the thought process by speaking up. The 10 for 10 principle is another tool to avoid cognitive lockups, especially in high-rush emergency situations. You state your hypothesis, the team acts on that hypothesis for the next 10 minutes, then you stop briefly, re-evaluate the situation, and then continue treatment or change the treatment based on a different hypothesis. So in summary, diagnostic error is influenced by a variety of factors, such as the conditions we work in, the availability of information, but also our personal risk-taking. A special clue to minimize diagnostic error means that we need both, thinking fast and slow, and the multitude of brains in teamwork. Thank you very much for your attention.